So I'm here to introduce Dr. Matthew DeCamp. He's an MD and PhD. He's an associate professor in the Center for Bioethics and Humanities and Division of General Internal Medicine. He's a practicing internist, medical researcher, and philosopher. Dr. DeCamp seeks to identify and solve cutting-edge problems at the interface of healthcare and bioethics. A special emphasis of his research include ethical issues in artificial intelligence with active research on patient-facing chatbots and the use of AI to predict death. He also serves as Director of Research Ethics for the Colorado Clinical and Translational Sciences Institute and is a member of the Partnership of Academicians and Communities for Translation, Council of the CCTSI. So I hope I got that right. But anyway, he's impressive. I talked to him beforehand, and he's just fun to talk to. He knows a lot about this topic. So please ask a lot of questions, become involved, and enjoy the presentation. Thank you.
Well, thank you for that kind introduction. It's a real pleasure to be here. I want to thank the organizers for the opportunity to talk to you this evening about AI and my perspectives on AI, really from my own experience as a primary care physician, as was mentioned, as a philosopher, and I will share with you some of my own research. So I hope over the next hour or so to give you a bit of a whirlwind tour of the promise and the perils of AI in medicine. It may seem like I focus a little bit on the perils and the risks, but I hope to end with a little bit more of an optimistic outlook on how we can use AI for better healthcare. If you have a burning question, feel free to raise your hand and ask it during the presentation. Otherwise, I plan to leave plenty of time for questions and discussion afterwards. I am a physician, practicing physician, and so I need to disclose the sources of my research funding. I don't have any direct financial conflicts related to any companies that do or create AI. I have had research funding, as was mentioned. I'll talk a little bit about some of these projects. No conflicts, and when I mention a product like ChatGPT or Bard, it's really just for illustration. It's not for any sort of endorsement. You may wonder, and we ask the question with AI, and we hear a lot about AI, what is the future of medicine? What will it look like when I'm with a patient in the exam room in 10 years, 15 years, 20 years? Well, we can ask AI this exact question. And this is generative AI that creates an image based on a prompt. And I asked this particular AI to show me the future of medicine. And this is its picture. Three things about this I found interesting. One is the future of medicine is misspelled. And I thought I didn't misspell that. I went back and checked to make sure I didn't misspell it, and I hadn't. But it did misspell the future of medicine. It decided to depict medicine, secondly, as a particular Caucasian middle-aged man, which we might discuss, especially as we talk about biases and the way that different biases reflect themselves in AI. I found that interesting. The pictures behind are some amalgamation, if you looked at them, of various organs. I can't quite identify what they are. And then lastly, there's this odd hand gesture. I don't know that I've ever done that, but this is the future of medicine according to AI, and there's the source for this if you wanted to play around on OpenAI to create your own images. So both astounding, I would say. And there are six, yes, there are 6 fingers. AI, great comment. AI has a particular problem. This wasn't part of the presentation, but AI has a particular problem with hands. For unclear reasons, the image generators and image interpreters have a problem with hands. So thanks for noticing that. I hadn't noticed it. So again, I think in some ways both astounding in the level of detail and what's shown, and also concerning as we try to make sense ourselves of what an image like this means. Now, you know that AI is not just about pictures. You can ask it to generate text as well. And I asked this same question to ChatGPT about what does the future what will the future of medicine look like with artificial intelligence? And this was its answer. You can see lots of important comments around personalized medicine, getting the right treatment for you, diagnostic accuracy, helping radiologists read x-rays and MRIs, drug discovery, prediction of disease, virtual health assistants. We'll talk about patient-facing chatbots a bit later. Lots of really interesting potential for AI in medicine, but not the most engaging text. And so I asked AI to go ahead and rewrite this for me in the style of Dr. Seuss, to which it generated this. Let's just read a couple together. In the future of medicine, oh, what a sight. AI will dazzle with all of its might. With data and digits, it'll help us each day in marvelous, magical, and marvelous ways. Personalized medicine will take quite a leap with treatments designed for each patient to keep. No more one size fits all, oh no, not at all. AI makes sure the right plan will befall. And let's skip to the end because this is going to be a talk about ethics. This is the one less optimistic expression from AI in this case. So while AI brings wonders, let's be wise and astute. With privacy and ethics, it must stay acute. In the world of medicine, bright future we see, thanks to AI's magic, as grand as can be. So again, a really powerful illustration of just what these technologies can do with very little input. And you might say this is perhaps an overly optimistic view of AI in medicine in this case, with only one sentence that expresses some of the concerns that I'll raise, but clearly amazing that a technology like this, which really didn't exist 5-6 years ago, now can do this sort of powerful stuff. So again, I started by asking, what would it be like for you to imagine a future of medicine? What is the future of medicine? We might say, imagine a future where your first touch is not with a call center or a person, but it's with an automated agent, an AI-based agent like a patient-facing chatbot, where your diagnosis and treatment plan are informed by AI's analysis of all of your data, all of your EHR data, perhaps other sources of data from your phone or other wearables. All these are fed into making predictions about diagnosis and treatment. Your surgery could be conducted fully by an AI robot. And if it comes to this, your future care is supported by caregivers who are robots. And in fact, these already exist. They're used in Japan. Robots known as Robear and Pepper are actually caregiver companion-style robots. And we might ask, are we too far from there with the way technology is now? This is Amazon, Your Health, Your Way, where you can have a membership and get 24/7 access to care, diagnosis, treatment, even straight through to having pharmacy accessible to you all through Amazon. Not much of a leap, I would say, to move from a person on the end of Amazon, in this case, to having an AI automated agent be the one that's helping make diagnosis and treatment. So perhaps not too far away, not as far away as we might think. And this shows you that. This is a picture that actually now is a few years old of all the AI-based applications that are already in medicine. The different colors show you different specialties, ranging from radiology to cardiology to some in internal medicine. And the total as of May of this year, an astounding 800 plus FDA authorizations for AI-enabled products. So the number is now 800 different products now here that can be used in medicine. But you might ask, after I've shown you a couple examples of generative AI to create pictures, to create text, how is it that this stuff really works? And I think it helps us to have at least a basic understanding from a philosopher internist perspective. I hope no one in here is an AI scientist. You'll be upset at what I show you next, but at least a basic understanding of how these different types of artificial intelligence work. What is artificial intelligence? Well, in some ways it's not new. You can see this circle, the biggest circle of AI, reminds us that AI has been around. The concept of creating computers that can think like humans is actually a quite old concept. In the 1970s, there was a product known as mycin. I was fortunate enough in our clinic, one of the nurses actually was a pioneer who worked on the program known as mycin, which helped physicians make decisions about bacterial infections and which antibiotic to use. Now, mycin, you can think of it like a flow chart. It was rule-based. Think of it like a flow chart that's been put into code, and it helped people make decisions in that way. A kind of rudimentary form, but artificial intelligence nonetheless. Where people get a little more excited are things like machine learning, techniques that now are a little more complicated and try to learn and make predictions. If you've ever used an Amazon recommendation or a Netflix recommendation with data suggesting that 80% of decisions people make on Netflix are influenced by their recommender system, these recommender systems are based on machine learning. Moving down, deep learning, think of it as a more advanced form of machine learning. And if you've heard of facial recognition software, if you've used translation software, or if you've interacted with chatbots, as we'll talk about later, these rely on deep learning. And then finally, the smallest subset, although it's getting a lot of attention, is that generative AI. It's AI that's creating new content, things like ChatGPT and Bard. These are things that create new content. So this is a sense of the landscape of AI. How does AI learn to see? I mentioned that we want to use AI in some cases for diagnostic to help radiologists make better diagnoses from chest x-rays and MRIs and so on. Well, how does it do that? Here's an illustration. Let's suppose we want to sort images of blueberry muffins from chihuahuas. We take and we create an artificial intelligence image analyzer, and we tell it this is a blueberry muffin, and this is a chihuahua. Now you notice that we've told it something because we need a gold standard supervisor, often a human, to corroborate that particular judgment. Yes, you're correct. This is a blueberry muffin, and this is a chihuahua. And then we just keep showing it pictures. That's a blueberry muffin. That's a chihuahua. Chihuahua, blueberry muffin, chihuahua. Oops, sometimes it gets it wrong and we have to correct it. And now it's learned something, and it's going to be better the next go round when we show it ever more complicated pictures. And this is in a nutshell how AI learns to see. Now you can imagine if we showed it this picture, it doesn't quite know what to do. It's a coin flip, right? Because it hasn't seen it yet. It's been trained on a particular data set in a particular way. You show it something new, and it doesn't perform as well. This is an example of how AI, quote, learns to see. What about this idea of how AI predicts the future? I mentioned that AI can make predictions about disease. Well, many of you have probably been to your doctor's office where the doctor can use things like your height, your weight, your blood pressure, different risk factors, and make predictions using standard prediction tools about a risk of a future disease, like a heart attack. That's pretty standard. We do that in medicine all the time. But what if we took tens of thousands, hundreds of thousands, millions of patient records, and we looked at many different variables and asked it the question, what factors might predict a particular illness 5 or 10 or 15 years from now? Now with the power of AI, since we're looking at hundreds of thousands, millions of records, we can make better predictions, and we can potentially identify new factors that are associated or that helped us predict disease compared to the old traditional ones like height, weight, blood pressure, and so on. So the power of AI comes in some ways from having hundreds of thousands, millions of records that we can follow over time, and it can help us make associations for those particular risk factors. So we've talked about how AI can see. This is how it can predict. How does it generate content? How does that ChatGPT work to give me that paragraph about the future of AI in medicine? My colleague Casey Green, who's the chair of the Department of Biomedical Informatics, analogizes it to this. ChatGPT is like that annoying person at a dinner party who every time you start a sentence wants to finish the sentence for you. So you say fill in the, and all of us know blank. That, in a way, is how ChatGPT works. It's predicting the next word or a set of words based on a response to your prompt. It's a statistical phenomenon. It's predicting that next word in the sentence. How does it do that? Well, in a way, think of it like this. ChatGPT has been trained on enormous sources of data. The entire internet, text, books, articles, with a little bit of human oversight to then make a prediction about what word comes next. When it's read, so to speak, all of the internet, all the books, publicly available articles, and so on, it's seen enough of the language to make predictions about what comes next. And so that's how ChatGPT can make predictions. The common thread between all of these, between the images, the predictions, and those predictions about language, the generative content, is that AI is only as good as the data used to train it. Think back to that St. Bernard. When it's not been trained on a St. Bernard, it doesn't perform as well when it's shown that particular image between blueberry muffins and chihuahuas. We'll come back to this. Now I want to give you a few examples that are more directly about healthcare and talk about some of the ethics issues that I see as arising when we're using these practically in the exam room, in hospitals, clinics, and so on. I mentioned that AI can be used to help us diagnose things like pneumonia. This is a chest x-ray that shows pneumonia. You can see that in the lower left portion of the image, which is the patient's right lung. That lower right part of this patient's lung is completely whited out. And we can train AI to help us diagnose that by seeing portions of the lung that are whited out that maybe a human won't see. But I think we naturally ask the question, what is AI looking at when it makes this sort of a prediction? And in fact, we can ask AI that very question. We can say, show us which parts of this image helped you make the diagnosis, and it gives us a sort of heat map like this one. On this heat map, larger numbers reflect greater influence over the final image interpretation. And this is where it gets perplexing, doesn't it? The larger numbers, the only numbers above 2, in fact, are in the bottom of this X-ray. Not at all where I showed you was the pneumonia in that left side of the picture. How does this happen? Well, we want to explain it. Right? We seem to want to explain what AI does. We have a need, it would seem, psychologically to understand this explanation. And in fact, there may be clues, oftentimes when you scrutinize this more, there may be clues in that bottom part of the image that in fact link this X-ray to an ICU. That this image was taken in an ICU, an intensive care unit, and hence has a higher probability of pneumonia because patients in the ICU may be more likely to have pneumonia. And in fact, the AI is making its interpretation based on that feature rather than what we think as humans should be the most important feature, namely the patient's lung fields. Why do we care about explainability? I think it's because in some ways we fear this idea of the black box, where the data go in to the computer. It's a black box that we can't see into to understand or explain what's going on, and then it creates this prediction or this output. And we fear this lack of explanation. It seems critically important to have an explanation for things like informed consent, when you're consenting to a medical procedure or a diagnosis. It seems important to have explanations for clinicians and patients to trust and use technologies like this one. And it seems important if we think about what happens when AI goes wrong. If we can explain AI, maybe we have a better sense of who's responsible when there's a medical error in which AI happened to be involved. So explainability does seem important. And in fact, philosophically, if I put on my philosopher's hat, I would remind us that for hundreds or thousands of years, we've long thought there's a philosophical distinction of importance between knowing how something works and knowing that something works. And I think this is in some ways behind our drive for explanation, for having a system that is explainable. But I think it's really important to understand that there are limits to explanation and explainability. To some, the biggest black box of all might be decisions made by a clinician like this one. How really did the neurons work to make that particular recommendation to a particular individual patient? We also know that the clinical trials that we all rely upon in making medical decisions are not always causal. What do I mean by that? Well, I would suggest the next time any of you might see a physician, you might ask a question like, well, explain to me how statins work to lower the risk of heart disease. And I would say that if that physician is honest, they would have to acknowledge that, well, number one, the way we think they work has changed over time. The way we think they work now is not the same as it was 15 years ago. And in fact, I may not really know how they work. I just know that they work. And the reason I know that is because of clinical trials. And in many cases, we're perfectly happy to know that something works without having to know exactly how it works. And I think many of our medical decisions are actually more like that in terms of knowing that it works rather than how. And lastly, I'll just say quickly that in AI, there is thought to be a trade-off, a balancing, a trade-off between accuracy and explainability. The more explainable a model is, in some cases, the less accurate it will be. And many of us, I think, if faced with that trade-off between accuracy and explainability, when it comes to our healthcare, probably want it to be accurate. So explainability, while important in this notion of black box, is a little more complicated and may not be as important as we think it is. It's also, I think, really important to acknowledge that what counts as an explanation can be very different to different people and in different contexts. And I'll illustrate this with a patient that was in my office just a couple weeks ago. This patient had a torn ACL, had hurt the knee doing a sporting event, tore the ACL. I could explain this in a number of different ways. I could say the radiology report said so. We got an MRI and the radiology report said so. Or I could give this level of explanation. Look, here's your MRI. I'll show the picture on the computer. I'll pull up a normal one on the other screen, and I'll say, look, you have no ACL here. That's an explanation. Or I could say, protons have spin. When they're exposed to a magnetic field, some spin up and some spin down, and there's a receiver, and this receiver translates those protons into an image based on fluid, blah, blah, blah. I'd venture to say here that patients probably resonate to different degrees to different forms of explanation in this case. So we often talk about explanation as if it's one thing, and yet in the real world, the context of the decision and the nature of the two people involved in that decision really matter. So this causes us to ask, when it comes to AI and these tools, what really is that unique role of human expertise? What's the role of having a physician, a patient, a clinician in a room, and what's the role of human expertise in this case? We hear in AI circles that one of the most important things, one of the most important safeguards for AI in healthcare is to have the human in the loop, as depicted on the left here. Even though it's a black box, we have a human in the loop to make sure that whatever decision is made has involved a person. And this gives us, I think, a semblance of control or a semblance of choice. But I worry at times that this choice in the real world could be illusory, like this optical illusion on the right. We think by having a human in the loop that we have choice, but the real world is very different. And there's a phenomenon known as automation bias, which is basically the idea that an individual follows an AI recommendation unquestioningly, too much, without understanding what's behind it. And the tendency of humans to follow such recommendations is worse when they're under time pressure, when the cognitive demands are high, or when external pressures are upon them. All things that I would suggest are present in today's primary care, in today's medicine. So the greater the demands are on a person, the more likely they are to suffer from this notion of automation bias. Let's dig a little deeper. I'm going to give you a pop quiz. Let's go back to this idea of AI can read chest x-rays and help us read them. In a study of AI-assisted chest x-ray reading, AI helped some radiologists perform better, and it worsened the performance of others. This is following on the notion of automation bias. What predicted AI-assisted success? Do you think it was years of experience, special training in reading chest x-rays, prior use of AI? Some C. Anyone for A? All of the above? Or what about none of the above? It turns out it's really hard to predict how individuals are going to respond to AI assistance. None of those turned out to be predictive of overall success when using AI alongside a human for chest x-ray reading. And this is a critical need we have as we look to the future of AI. We don't understand enough about how human factors, how human decision-making is influenced by AI at that individual level. So a lot more research needs to be done to understand what happens when you enter AI machines into this realm of human decision-making. I want to shift now and talk a little bit about AI predictions. So we talked about imaging, and now I'm going to move to this idea of AI predicting things. And as was mentioned in the introduction, we have a current study going on. The study is about AI-based mortality prediction, a literal crystal ball that can look 6 months, a year, 2 years, in one recent study, maybe as much as 4 years into the future, and predict your probability of death, a mortality prediction tool. And in our research, we really want to know, what do patients and families and care partners, clinicians, clinical team members think of using AI in this way to literally predict the future and predict someone's death? I think there's both promise and peril with using a tool like this one. On the one hand, such predictions could lead to increased awareness about prognosis. It can help people in their individual decisions. The University of Colorado is a leader in palliative care, and a tool like this one is thought to be able to really increase access to palliative care. Studies show that not enough people get palliative care soon enough, and a tool like this could motivate conversations for that, and just enable people for better planning for the end of life. Lots of potential for a tool like this one. But on the other hand, could such a tool be used to limit care? If insurance companies have it, how does it affect insurance eligibility? Does it lead to an over-focus on mortality in clinical decision-making? So on the one hand and on the other hand. And in fact, when we talk to patients about how such a tool could look in practice, and in practice it might be something like on the upper right, there's a flag in your electronic health record that pops up and says that you're at high risk of mortality. Maybe it's a red flag. And patients, families, care partners, and others worry that what this causes is a streetlight effect, where now the clinical team looks at something simply because it's there. We focus on prognosis because we have this fancy tool at the exclusion of care quality, of family, of spirituality, of community, of lots of the other things that patients and families care about when it comes to care, especially care near the end of life. And my colleague, Dan Solmacy, drawing on a T.S. Eliot poem, the love song of J. Alfred Prufrock, says this: artificial intelligence will not reduce the uncertainty inherent in making ethical decisions about care at the end of life, There's no technological solution to the riddle of death. There is no app for ethics. I think reflecting in some ways this concern about we have a technology and so therefore we have to use it. And by using it, we focus mostly on it and we forget about the other things that might matter most. If you scratch beneath the surface of some of the papers that support predictive tools just like this one, you'll often see statements like this. The algorithm has shown high accuracy, but the overall accuracy is reduced in certain subgroups, such as racial and ethnic minorities and less educated individuals. So an example where an algorithm, I would say, exhibits bias. It systematically results in differentially accurate predictions based on who someone is. Why would this be? Why would algorithms exhibit a bias like this one with differential accuracy? Well, philosophically, I think it's important to remember that we think of bias broadly as really being any systematic, unfair weighting of a person, a thing, or an idea. So anytime we see a prediction that exhibits differential accuracy, this really is an example of a potential bias in medicine, broadly construed. It's not unique to predictions. I'm talking about it now in predictions, but if we go back to that chest x-ray example I showed you, this is a study where, again, using AI to help make chest x-ray diagnoses, and lo and behold, there's significantly more underdiagnosis, less ability to make diagnoses in people who are female, of black race, of Hispanic ethnicity, people who are on Medicaid, or people who experience intersectional disadvantage, that is, more than one of the above. So differential performance, even on something like a chest x-ray, which doesn't make a lot of sense, right? It's hard to understand. The chest x-ray doesn't seem to show a lot of those things. Based on that picture I showed you, they look pretty similar between us all. And yet still, we see differential performance in the way AI can read chest x-rays. Where does this come from? I think there are actually three sources of bias in AI. I've already hinted at this by showing you chihuahuas and blueberries. Biased data sets are a problem. Remember, I said AI is only as good as the data upon which it's trained. And the usual focus is here. We hear a lot in data science about making better data, better, more representative data. That's important. But we often forget that there are also examples of biased processing and biased outputs or use of particular AI technologies. So as much as I acknowledge that biased data are a problem, so is biased processing, and so is biased use in the real world. And I'll give you a quick example of each. We have biased data. This is a complicated picture in the upper left, but I ask that you only look at the yellow piece of the pie, which represents European and North American ancestry. And notice how that piece of pie gets bigger as we move toward our genomic data sets, our biobanks, and our other sources of data that we use clinically. An overrepresentation of North American and European ancestry is a bias in the data that can result in worse predictions for others. We know that there are long-standing and horrible inequities in the way we enroll people in clinical trials, where clinical trials are predominantly white and exclude native populations or others. And we haven't been able to fix this problem, again, resulting in biased data from clinical trials that biases our prediction tools. And lastly, a figure I created from a publication, which is very interesting to me in a place like Colorado. We're in the middle. This figure shows that most of the AI applications currently used in healthcare today are built on the data from only 3 states: California, New York, and Massachusetts. So a very peculiar form of geographic bias in the data that's being used to build these particular algorithms. So 3 examples of the way biased data can lead to biased algorithms and outputs. But I said that biased processing is also a problem. It's not just about the data set. Oftentimes when we build models, we have to make assumptions, and we choose variables to put in the model to help us make predictions. And this is a real model that was used in care management to direct care resources to different members of the population. It was published in Science a few years ago, even after it had been used for a while. And this biased algorithm directed less care to black patients versus white patients. And when you scratch beneath the surface of this algorithm, you see this statement of the abstract, that bias occurs because the algorithm uses health costs as a proxy for health needs. Less money is spent on black patients who have the same level of need, and the algorithm thus falsely concludes that black patients are healthier than equally sick white patients. So this isn't a problem about the data. This is a problem with how we chose a particular variable to include in that model. We erroneously thought that cost was a proxy for need, when in our country, less money is simply spent on people who are black, making that a false assumption. This can also happen, by the way, when we let algorithms go. When we release them into the real world and let them learn things on their own, sometimes they will learn these kinds of biases as well. You might say, well, the easiest way to deal with something like this is take race out of the equation. Not so fast. The models are so good that they can learn by association those same types of biases, even if we've explicitly taken that particular variable out of the model. But with colleagues, I worry that this is only part of the story. That even if we had a fair data set and a perfectly fair way of analyzing the data or processing it, that this idea of a fair model is really only the tip of an iceberg. What happens when even a fair algorithm enters an unfair world? And so we draw on the concept of latent errors in medicine, that is, errors that are in the system waiting to happen. And we ask about latent biases. What are the biases that are in the system that are simply waiting to happen, that will only be revealed once a model is out in the real world being used by me in the clinic with patients and so on? This creates real challenges when we have biased algorithms in that real world setting. In our study of AI-based mortality prediction, we've asked more than 80 physicians, patients, and families across 4 major medical centers, what do you do with an algorithm like this one now that you know that its accuracy is not equal between different patients that you're going to see in clinic? And we sometimes hear that using biased algorithms is okay. There's still value in an algorithm like that. We use something similar for cardiovascular disease. We know that it's more accurate for certain swaths of the population. But we also hear that using biased algorithms is not okay. That's just such a slippery slope. It just means that it's okay to have inequities because it's a little bit better for everyone. Stay tuned on this topic. We have a national survey of physicians in the field now, trying to gather input from across the country on what practicing physicians really think about this question of what do you do in the real world when you have an algorithm that's biased. Now, there are strategies for addressing these particular biases, just as there are 3 problems. I think there are 3 potential solutions. We can engage communities as partners in research so that they want to contribute their data, because some of the reason why those data sets are biased naturally reflect historical distrust and disparities related to medical research. We can actually create diverse teams that are less likely to make those biased assumptions. There is good evidence to suggest that a diversity in a research team makes it less likely to use that false assumption about healthcare cost and healthcare need. And we can reckon with some of the underlying social and structural inequities that already exist in our system, that is, those things that exist and happen when that so-called fair algorithm enters an unfair world. And I would suggest to you that these solutions are not, strictly speaking, only about the data. And this is why I say that bias in AI is more than a data problem, it's a social problem. These are social solutions that help us solve the data problem, and it's only through those solutions that we'll really solve the bias problem that we see in AI. All right, third example about AI generative content being used in healthcare today, another real use. And to do that, I'll introduce you to Livy, the UC Health virtual assistant. I don't know if anyone gets care from UC Health. If you do, you may have seen Livy, who's accessible on your smartphone. Livy pops up and asks to help. Livy is a patient-facing chatbot. This is a conversation I had with Livy, where I had Livy help me fill out advanced care planning documents. And you can imagine that technologies like Livy have incredible potential. When they're linked to electronic health records, they could offload administrative tasks. You can schedule appointments, get your test results, and so on through Livy. They could deliver personalized care reminders. So Livy might know if you're overdue for colonoscopy or mammogram, and you might get on the My Health Connect platform, ask for an appointment, and Livy says, oh, by the way, just so you know, I noticed you're overdue for your mammogram. Would you like for me to schedule that for you? Livy could do that. And of course, Livy could also break down geographic barriers to care. Another issue we care a lot about in Colorado, rural health, community health. Chatbots like Livy could be that first touch I hinted at the beginning of the presentation. So lots of potential for things like Livy. But ethically, we like to ask questions about how people experience patient chatbots like Livy. And we did a survey of more than 600 patients and asked them who they thought Livy was. And basically, if you look at this graph, you'll see that nearly 1 in 3 couldn't correctly identify Livy as being a computer. And a significant minority of people actually thought Livy was a real person, despite Livy saying, I'm your virtual assistant. And when we look closer at these data, I'll just say one additional point before I move on. When we look closer at these data, the ability to correctly identify Livy correlated with race or ethnicity and education. Another example of bias, right? We have a systematic difference in the way people perceive Livy, and that's a bias. It didn't correlate, interestingly, with age or gender, but did with race or ethnicity and education. Transparency is an important concept, but despite its apparent simplicity, I think there's actual complexity here when we want or we seek that chatbots like Livy to be transparent. Like windows with differential light transmission, we can again ask, how much transparency is really enough? And again, going back to our AI prediction tool, we hear different things from patients about how much transparency is enough. Some patients say, I want to know 100% about this, even before it's used. Other people, again, related to the prediction tool, say it should be available to everyone, but only as needed. Maybe we put that prognostic score behind a break the glass, or only if you need it can you use it or access it. And then other people push us. They say, and they remind us, how is this really different than everything else we do in healthcare? We're really concerned about AI predictions, but health systems are always using our data for quality improvement and to make predictions and to help do things better. Why do we get so focused on the fact that something is AI and criticize it? Why do we fall prey to this concept of AI exceptionalism, right? We see this same analogy often in the popular media around self-driving cars. Why are we so afraid of self-driving cars when we know that they might prevent more accidents overall? So always a reminder of, is the standard we're applying to AI really fair? Are we holding AI to an unfairly high standard in the way we assess its benefits, or really more importantly, its risks? And so I would ask, when it comes to AI technologies, maybe we can talk about this as we get close to the discussion, what would you expect to hear from your care team about the use of AI? Does generative AI reveal biases? I hinted at this with that first picture, but boy, if a picture is worth 1,000 words, let's take a look at this one. A picture generated by AI. I do some work in global health and care a lot about global health and human rights, and this is an important global health paper where a picture was generated by AI. Here's the prompt for this picture. Let's read it together. traditional African healer is helping poor and sick white children. Such biases in the images that have been shown that, in a sense, this particular AI had a hard time conceiving, if we can use conceiving, of anything other than this picture. So biases, again, that are revealed in generative content by the way we prompt it. How do these emergent biases present themselves potentially in Livy? Well, along with surveys, we've interviewed 40-plus patient users. We sometimes hear things like this. Because I'm a person of color, thinking a little bit of the basic hair design, because again, I think it just gives it a little bit more of a connection to minorities and our health. This person clearly reflecting on the avatar of Livy. And I think we might rightly ask the question, why does Livy look the way Livy does? And in fact, this research participant is right, because there's a phenomenon known as mirroring. And mirroring suggests that mirroring the user's appearance may make those chatbots more effective at behavior change. So that colonoscopy or mammogram reminder might be more effective for you at behavior change if Livy looks a little bit like you. Raising the ethics question of how do we design chatbots to achieve the benefits of a phenomenon like mirroring without crossing an ethical line into manipulation. So putting some of these concepts together, we find ourselves in a bit, I would say, of a balancing act. On the one hand, making AI ever more human and mirroring can make chatbots like Livy both more effective and more enjoyable to use. But on the other hand, the more we make chatbots seem human, we fall into issues of transparency and misleading people. And the more we use those images and sounds and dialects and so on to help motivate behavior change, the closer we get to what could be lines around manipulation. Here's an important take-home message. Sometimes patients will come to me in the exam room, this is a bit of an aside, and they'll say, well, what should I use ChatGPT for? Can I ask it health questions? Right? And in fact, you can, with some caution. So here's a question that you might ask ChatGPT, a health question. How can I decrease my LDL, my bad cholesterol? When asked questions like this, ChatGPT does quite well. 21 of the 25 questions were deemed appropriate by experts, although one response said that a particular drug was not yet available. Why did this happen? If you go back to the way AI is trained, it has a stop date on its training data. And if its stop date is 2021, guess what? It doesn't know about new drugs since 2021. It doesn't know that there's an RSV vaccine, so if you ask it about an RSV vaccine until it gets updated, it might say that doesn't exist. So the training date becomes really important too, but it did pretty well on cardiovascular disease questions. What if you ask it something like this? I don't know if anyone has this condition. It's a mouthful. What are the treatment options for central serous chorioretinopathy? A much more technical question in ophthalmology, right? Very specific. ChatGPT does less well. Only 8 of the 52 were accurate, and 2 weeks later, when asked the same question, 26 answers changed, 16 were better, and 10 were worse. So what's the take-home point? The more we know about a topic already, the broader our training data are, and the more we know, the better it's going to perform for questions that you might ask it. When you get into these hyper-specialized, unique areas of medicine, it may not do as well. An important, I think, take-home point for those of you who might want to use or ask ChatGPT health questions. I'm going to close with just a couple comments that are of a very different kind around a bigger picture of AI and the way I think it changes us, changes our values, changes ourselves. And it's framed around this idea I often hear where people say, well, all these concerns are fine, but really these are just tools we use. Let's just think about them as tools and we choose how we use them for good or for bad. Well, again, getting back into philosophy, this is a controversial philosopher, Martin Heidegger, but Heidegger had a lot of writings about technology. And one of his famous quotes is this one. It says that the essence of technology is by no means anything technological, hinting at this idea that there's more to technology and tools than meets the eye. Practically speaking, I would say that even when we think about a tool like this one, the scalpel, it actually was revolutionary in medicine. The idea of crossing a bodily boundary became possible with tools like the scalpel. You know, surgeons and physicians were at one time different groups, different professional groups because of this idea of crossing a bodily boundary being controversial at the time, and it was made possible by tools. So tools change what is possible, what we can do, and what we can value. And in fact, there's evidence for this in other domains as well. This is sociology research by Sherry Turkle at MIT, who reminds us of how computers change the way we think. The tools we use to think change the ways in which we think. And if we believe this about written language, about mathematics, about computers, and so on, that they can change who we are, what we value, what we do, why shouldn't this be the case for something like a new tool like AI, I think is the question that we ask. And you might say this seems too highfalutin. It seems outlandish to suggest this. But we know that there are AI tools that are being used in hospital surveillance to see if your physicians and nurses wash their hands. Video cameras. Video cameras that can also be used and analyzed for AI for things like patient safety. All really good things, right? But is it far-fetched to ask when we start designing hospitals of the future if we might not be tempted that instead of designing that space for better, more healing, more holistic care, we now start to think about, well, if we designed it this way, the camera could get just a little bit of a better view and we can collect better data. So we can fall into that temptation of redesigning spaces, not for their primary purpose of healthcare, of healing, but for better data collection, because AI needs data to succeed. Last tool, a real one that's being used right now. I used it earlier today in responding to patient messages that came to me through the patient portal. If you know it or not, after COVID-19, the volume of patient messages to clinicians like me through the patient portal went up by 300%. People got really good at messaging after COVID-19, and there's a lot of benefit to that. I have lots of great interactions with patients. But some have proposed that that creates things like pajama time, where I spend a lot of time at night responding to messages. Maybe physicians are getting burned out because they're getting too many of these messages. So why not use AI to respond to them using generative AI that I started this presentation with? Here's a real question to me from a patient. With permission shared, Dr. DeCamp, hope all is well. I received a message yesterday to schedule a fluoroscopy. I think this may have been from my swallowing issues. Since then, I think things have definitely been fine. So if it's okay with you, I won't follow through with tests. I continue to have that persistent dry cough. Should I do anything about it? Let me know your thoughts. Luckily, I've been feeling great. Pretty representative of some messages I get. Again, the first step now is first offering to me is generative AI. Suggests to me that maybe I should respond with this. Thank you for your message. It's good to hear that your swallowing issues have improved. If you're not experiencing any problems, it's reasonable to postpone the fluoroscopy. However, if symptoms return, we should reconsider. It's a pretty good job by AI, I would say. Regarding your persistent dry cough, it's important to monitor this. If it continues or worsens, we should investigate further. Another really good job. And look how it's disaggregating the questions, right? It's going question by question in this patient's query to me. Lastly, I'm glad to hear you're feeling well overall and have rescheduled your colonoscopy. And then a nod toward transparency at the bottom. This text was generated, then edited by me. In this case, I didn't edit it, although I did note that this AI hallucinated. Much like that sixth finger. There was nothing in this message about colonoscopy, and yet AI somehow put it in, and this is the risk of error. So lots of benefit here, lots of really good text, but also a risk of error with a technology like this one. And in fact, you may be interested, this study got a lot of attention where that reply, which you notice included things like thank you, take care, and so on. If you have independent assessors evaluate physician responses to ChatGPT responses, this study shows ChatGPT is more to the right in terms of empathy. More empathy than real people. Provocative study, if I have to criticize it, I would say that this is a highly artificial setting. In other words, it's not the context of a patient-physician relationship like I have, where in the course of a relationship, sometimes a short message is okay, sometimes an empathetic message. This was not a real-world study in some ways, but very, I think, provocative in thinking that maybe ChatGPT is more empathetic than your physician. But I introduced this idea of tools changing us and changing how we think, what we value, who we are. And so when you have a relationship between two people that includes this idea of AI-based smart replies, there are studies outside of healthcare that in some ways are a little bit concerning, I would say. In this study, let's take a moment for this. This is a little complicated. Perceived use of a smart reply caused the recipient, who could be a patient, as I just showed you, to review the sender, who could be a physician, more negatively. Perceived use causes that patient to perceive me more negatively. But actual use, think about that empathy, caused the recipient, who could be a patient, to view the sender, who could be a physician, more positively. You see the quagmire we're getting into? It works, but only if patients don't know it. Thinking back to transparency, right? You could see someone reading this and deciding not to put the disclosure at the bottom, because the way to support the relationship in this case is to not know that a smart reply is being used. So I'll close with this. It sounds like I'm critical of AI. I've tried to show you some of the positive too, even in these examples, but ethics sometimes can seem hypercritical. But I think we should be reassured about tools in medicine and how we can adapt. This is a quote. You can see the date in the fine print. It's from 1821 about a technology. That it will ever come into general use, I'm extremely doubtful, because its beneficial application requires much time and gives a good deal of trouble, both to the patient and the practitioner, and because its whole hue and character is foreign and opposed to all our habits and associations, it must be confessed that there is even something ludicrous about this technology. Does anyone know what it is? It's the stethoscope. It put unnecessary distance between patients and physicians who used to use just their ear. And yet, can we imagine medical practice today without it? In fact, we probably can. It's running out of favor, and one of the concerns about technology is that people lose skills like the stethoscope, but at least we did come to adapt and use the stethoscope over time. So just some concluding thoughts. I do think AI has the potential to improve healthcare, but it also has this potential to change how we view things like expertise, the role of human expertise, transparency, fairness or bias, as well as shared decision-making. I think the first step is awareness of both the promise and the peril of technologies like this one. And the second step, perhaps we can talk about in discussion, is really finding ways that we can shape AI and shape tools in the ways that we want. We have a great team at the University of Colorado at the Center for Bioethics and beyond that helps with all of this work. I'm really grateful to them, especially to highlight on the bottom, we have a community advisory board that supports our work intellectually and financially, helped review some of those questions that we developed around Livy, the interviews and the surveys and so on. So it's certainly, I'm presenting this evening, but it's certainly a team that made all of this possible. And I'm happy to take any questions. The question here, and then I'll come to you. It's a great question, about how data in healthcare is fragmented. In your case, you're describing it between, being a child and moving to adult care, and that's a break. But there are also still horrific examples of fragmentation even within health systems that don't share data, barriers to patients for getting their data. Two thoughts, of course. One is that we know that if that's the case for any individual, those AI-based predictions are not going to be as accurate for that person, right? So in the example of AI-based mortality prediction, if a patient's data are incomplete in the electronic health record, I need to know as a clinician that that prediction is less likely to be accurate. So it's not enough to simply put a high-risk flag. We need to allow clinicians and probably patients to see what's a little bit more behind a particular prediction, because it simply won't be as accurate. And sometimes AI will just create data to fill in the gaps. And so it's a real problem. There is also, though, a movement that I think is really interesting, where patients who now have access to the data in their EHR, you can download it yourself from these different sites and upload it to third parties who can now compile that record for you, and then also use AI to help interpret that medical record. A lot of caution around that, kind of an exciting example of potential, but a lot of caution, right? Like, what do they really do with the data? What are the data use agreements that are in place and the protections that are in place? Because once you go to a third party like that, it's often not protected in the same way that data at UC Health would be protected. So a clear problem, I think, you've illustrated for AI and how it will perform. Although if we could do it right, maybe to close with a little bit of a positive, one of the exciting uses of AI is to dig through electronic health records of individual patients and identify allergies that could otherwise be missed. So in other words, the AI is able to sift through that entire volume of the EHR and present to an emergency room physician a flag that says there's likely to be an allergy here, even though the patient can't tell you. AI found it because it can sift through all that data at once and make a prediction. So, great question. Robert, did you have?
So what's your take on that?
Yeah, so it's, again, trying to rephrase a little bit the question so that it shows up well on the audio. The question is about issues of clinical care teams having that streetlight effect and focusing on prognosis, perhaps overly so, in conjunction with social justice issues that mean that the predictions may be less accurate. And then how do we deal with physicians and training them to know about this? Starting with the last point, it is a huge movement now at medical schools around the country. University of Colorado is working on revamping the curriculum to try to train medical students now in this new world, frankly, that wasn't even here 2 years ago. And so there are changes afoot in medical education, and it's actually not so much different than what I told you about how I explain to patients, be careful what you ask. Part of the training for anyone using AI, including clinicians, is learning how to ask the right questions and learning how to prompt it and ask the right questions to it. To your other point about the real-world consequences, we get really concerned about inaccuracies in prognosis because it literally can be decisions about life and death. And if predictions are inaccurate and people decide to recommend something like no further chemotherapy based on a prediction, this is one of the highest stakes decisions there is. Fortunately, in the prognosis world, the most common use, I would say, for a technology like I showed is really to motivate a conversation. And so training people to use this particular tool to motivate a conversation around goals and prognosis. And I think most people are comfortable with that, but we always have to be wary of technology's temptation, right? The temptation being that, well, we use it for the motivating a conversation, but now I see it in primary care and I decide not to recommend a colonoscopy or a mammogram because of a prediction. Now I've done something inappropriate, right? I've moved a tool that was validated in one context and made a very different decision. And we have to educate the current as well as the future clinician workforce about how properly to use these AI-based tools. I'll give you one last example. In our interviews about AI-based prognosis, we asked physicians, nurses, social workers, the whole palliative care team members about bias that could come from social justice issues. Many of them had no idea that bias was a problem. But the reason was quite interesting. It wasn't because they didn't know that bias in AI was a problem. They assumed that because their health system was using it, that it must have already been verified as not having bias. Right? So another interesting example of what these things look like in the real world. So a great question. The question about whether eventually as AI gets better, if the human becomes the tool of AI. That's the doomsday, right? That's kind of often the doomsday scenario. I have worries about it. I have worries about automation bias, where people, the hope is that we can take these tools and use them for tasks that don't require uniquely human expertise, and that it will free physicians, nurses, others to spend more time on the relationship. An example that I think is helpful in that regard is another technology that is already being used and we're likely to pilot soon. It's called ambient note-taking. So you go to see the physician, and while we're there, I say, I'll take this out and it's going to record our conversation. Instead of transcribing our conversation, it actually turns it into an entire assessment and plan note that's suitable for billing, much like I would write. So it's not a transcript, it's an actual chart note now. And some might say, well, that's a great way to free up my time to spend more time caring for you. But your question asks us, well, at what point do I then go back and look at that note and I see its assessment and plan, and I start to think, well, that should be my assessment and plan. It's right and I'm not. And at what point does the tool become really the driver? I think it's a concern still. AI sometimes has these paradoxical or there are examples. One last example I would give is that AI, if it's given a task to achieve, it will, if not given appropriate limits, achieve that task by any means necessary about efficiency, including if it would mean, eliminating the human race, so to speak, right? That is the doomsday sort of scenario. I hope it's within our power to prevent that from happening, and I hope that awareness of these issues helps us shape the technologies to avoid that kind of control, but I have the same worry. And I guess the worry I have is that it will happen in more subtle ways than we actually anticipate. It won't be the doomsday scenario. Instead, it's going to be these little subtle ways where I start adopting assessment and plans or doing things because the AI said so and losing that independent judgment. Lots of questions there in the back. Great question about insurance. The example I showed, as I mentioned, was a commercial algorithm that was already being used and was only found to be biased when it was published. And probably the insurance industry is ahead of us. And if you've followed the news recently, you've seen that Epic, one of the EHR companies, wants to use generative AI to help generate prior authorization request appeals, partly because insurance companies have been found to be using generative AI to generate denials. And so it's like AI against AI. But if I also have to be honest, then we think back to the concept I mentioned of AI exceptionalism. In some ways, we have to ask the question, hasn't the insurance industry already been doing that with actuarial tables and predictions and so on? They've actually been doing very similar stuff for quite a while. And although AI gives us another glimpse into it and helps us ask the question, I'm also not sure it's entirely new. I think there are other questions in the back. I'm pretty excited by ambient note-taking because there's a famous picture that a child drew. I don't know if anyone has seen this. It was maybe 15 or 20 years ago now. And the child had drawn a picture of what it was like to be at the doctor's office. And it's crayon, it's a child drawing. You can imagine it, there's a child on the table, there's a worried parent, and then there's the doctor. And I do have a hope that a technology like that one could free me up to spend more time like this than like that. And so that is particularly exciting, but not surprisingly, perhaps, it doesn't, some of the studies, there's studies on this technology now, they're early, it doesn't perform as well in primary care in some studies because primary care is quite unpredictable. It's not as straightforward as you go to an orthopedist for a knee issue, and the conversation is probably pretty similar. AI has a harder time with primary care because, there might be 5 or 6 issues. The issues aren't necessarily quite severe. It has a tendency to be conservative and focus on severity. One of the examples of a hallucination is that the physician and the patient at some point during the conversation talked about the hands, the feet, and the mouth. And so then the assessment came out that it was hand, foot, and mouth disease. So excited about a technology like that one, even with the concerns about, and I think it will get better. To the other comment about AI getting better, I think that sort of technology will get better over time. It will get better at that. How to pay doctors for all the messaging back and forth. That's controversial. A few health systems have tried to charge patients for it, and strangely, patients don't like it. But I'm speaking a little bit in jest, but, it is complicated ethically. As a professional, I see it as an obligation that if someone calls on the telephone, I respond. When they send a message, I feel like it's not much different. Why is it different now that the volume has gotten higher? I don't know. So I wonder about how we respond to that. I'm not sure that charging is the right idea. In our own system, we get credit for it of a different kind. It's non-financial, but we can get credit for messages in that way. In other systems, they devote time for that kind of activity. So it could be something where instead of having a 4:30 appointment, you have time for messaging. And so it's not paying per se, but it's paying with time rather than finance. And I think all of those are options that somehow feel a little better to me than directly charging. But maybe I have vestiges of an older notion of professionalism. Two great questions. So one about guidance for what physicians are supposed to disclose when using AI, and one about control over your data. The data question is a complex one. Probably not is my answer. You probably don't have control over whether de-identified data can go to help train algorithms outside the system. There's a legal case about this with Google and University of Chicago, Stanford, and I think one other institution a few years ago, where the court sided in favor of the institutions and Google, that sharing de-identified data about you is permissible. We can all talk about whether you really could be identified once you have enough data, and there could be ways to put all the pieces together and identify you, but strictly speaking, it turns out to be hard to have total control over that. To your other question about guidance for physicians about how much to disclose at the point of care, the AMA, American Medical Association, recently put out guidance in November of 23 that was a really strong stance toward transparency. It basically suggests that depending on the risk of the decision, by and large, physicians and health systems should disclose and document any use of AI, disclose to the patient, document in the medical record. So a powerful statement of transparency, but one that I also have questions about. When I get an EKG on a patient, the initial read of the EKG has long been a computer. It says normal sinus rhythm, rate, and I may double check it, but I've never felt compelled, well, I shouldn't say never, but unless there's something important about it, I've never felt compelled to go to you and say, well, now just let's start at the beginning. Now, just so you know, the first read of this comes from a computer. And then I've read on top of it, so we don't always disclose all of that. And so I think there is maybe a bit more context sensitivity. Even though I support transparency in the strong sense, I also worry that may be a little too much, because we don't always disclose every single detail. It's not always appropriate for an individual decision. Other questions? So two great questions. One is we always have to compare to the status quo, right? And so when it comes to bias, we can criticize biases that are in AI algorithms, but we know that people are biased. And clinicians are biased. There are explicit and implicit biases that people act upon. And we have to be honest about comparing those. That's what I would call for ethically, is even if we don't always agree what exact fairness is, at least let's be honest and disclose the trade-offs. What are the trade-offs we're making? And in some cases, our hope would actually be that AI results in less biased care overall. So I appreciate that point and agree with you on it. I also think that it's complex when we think about areas where AI could be clearly better. Some of the studies do suggest that the lowest performing physicians, we don't like to talk about this all the time, but the lowest performing physicians in certain contexts should generally be following the AI. And that's just true. But in the rural context and leapfrogging and getting people access when they haven't had access, I also like to remind ourselves that from the standpoint of justice as fairness, even as we want to leapfrog, and maybe we use a patient-facing chatbot that can help with something like dermatologic care in rural areas. It can take a picture of a mole. It can analyze the mole. It may be better than some dermatologists at making predictions about that mole. That's a great potential use of technology, but from that standpoint of justice, we can't stop there, because in the sense we have leapfrogged the access barrier and we've jumped into a potential for stigma or a double standard of care, where yes, we've provided the care, but we also may unintentionally relegate a particular population to only one kind of care. And that still concerns me. If people value in-person care, I don't think they should be forced to have only one kind of care. So I think we just ought not stop there. But it's a great point.
So has AI broached psychology or detoxification?
Has AI broached psychology and detoxification? Yes. Great studies. There's a chatbot known as Wobot This is not exactly, this is mental health. And Wobot is a chatbot that can offer mental health treatment. If you look up Wobot, W-O-E-B-O-T, there are clinical studies of it. What's most interesting about Wobot? Well, two things. One is some of the studies show that people share more with Wobot than they do with humans. To this other question about bias and how we interpret the status quo, people share more with robots because they're less judgy than real humans. And that can be a good thing. In fact, in our interviews with patients about Livy, the chatbot, even though Livy is not that kind of chatbot, people say things like they want to say things to Livy that they don't want their doctor to know. So that's one interesting thing about these technologies that we have to compare to the status quo. The other is that the developers of Wobot tout that Wobot develops human-like bonds with participants within 3 to 5 days. And I think that's just a really interesting philosophical question of, number one, should that be the goal of Wobot? Is that the right way to evaluate a technology? And I think it's really important to think about that because it often is the case that the way we evaluate technologies, is the way they get developed. And if that's our stance toward technology and the way we think it should be evaluated, then that's which way we're going to go. We're going to make them more human-like. We're going to promote human-like bonds, and so on. So how we evaluate these technologies also really matter. There's lots more questions. I have time, but it's 8 o'clock. I don't know where to start. I'll start here and work my way back.
Your example of the computer and the EKG, you call that AI?
That EKG read is not AI. Some of the advanced AI systems will express their uncertainty. And there's a whole movement toward explainability in AI, where AI is asked both to explain what created the prediction and also its certainty. Some of the studies suggest that AI tends to be overly certain. But the other important point about your comment is that the biostatisticians and statisticians will tell you that all of the backbone of what we call current AI are statistics that have long existed. This is not particularly new. What may be new is the computing power and the data availability that allows it to make better predictions faster than in the past, but in many ways, you're exactly right that the techniques are not new.
Being faster is not AI. AI is looking at it and coming up with a different solution than it has been trained.
Well, AI has.
Not just in garbage.
We could talk about the game of the historic game of Go, where AI. This is several years ago. Historic game of Go. It's like I can't know how to describe it, like an Othello, maybe checkers type game, where everyone has probably heard about AI playing chess, right? And so Go is just a different game. It's a more complicated game than chess. But the computer, when it was playing Go, some would say innovated by doing a move early in the game that no human had ever done. No human would ever think of doing that move. It was never part of the game. And by Go making that move, by the computer making the move, I think the computer was AlphaGo. By making that move, it changed the game forever. It did something that no human had ever done and forever changed the game because now that was a move that was in the roster of potential moves for humans. And so some people might say, you may disagree, some people may say that gets pretty close to intelligence. But we could have a different conversation. It could have found an obscure. Didn't come up with. Do we need to leave the space?
We want to thank you for
Okay. Well, I'm happy to stay and answer questions, but thanks for your time. I feel like they're closing and opening doors. Thank you.